How is it that you can do 10 and 13 pairs or even more of orthotics at one time? I'm going to go over that in this episode of Podiatry Practice Mastery. I'm trying to help you get your practice to the $1 million mark and beyond. Now, it might seem pretty amazing, but this is an experience that one of my colleagues had in our office. So let me tell you. So Ben is one of my partners, and he was a Division I athlete in college in Providence. And Ben just kind of he's a great surgeon as well, and he is very athletic. And so he had kind of made friends with the athletic trainers at one of the local colleges here. And he was his alma mater was Providence College. So what he said, and as he was visiting them, he went there and did kind of like some screenings, kind of looking at their feet, looking at their function. We do a lot of sports medicine. And I was just so impressed because he got to know the athletic trainers. And he kind of watched them. So these were college athletes, Division I athletes. And what he said to me, he said, Don, these groups, they have a lot of money for their student athletes. And so what he did is he went to these colleges and said, hey, you want me to screen your athletes and then I can make them orthotics? And they're like, sure. So he went one time, he said to Providence, and he had 10 pairs of orthotics. Like, he screened them all, 10 of them needed. So all the basketball team, I think it was. And then he said even better, he screened some soccer team. So they got 2 pairs. So they got the pair for their regular shoes and then the pair for their soccer cleats. And then he went to Holy Cross, got 13 pairs. And so the benefit of this is, I just think about it, so the students are changing every year. So we can go screen them every year and just get this. So this is something I've never heard of as a method to do this for your practice. Now, he said, does he do a full exam and does he do everything in the EMR? No. So it's not an office visit. It's nothing like that. He does a discount as well. So instead of doing $600 a pair, he charges them $500. He puts them in and he takes one medical assistant without a little scanner, and he scans everyone. And he makes them the orthotics, and I don't know if he might drop them off there afterwards and then fit them for them. But then, and then I guess the other ones, if they need treatment, they're going to be sending them over here. So he said some of these things. So I just wanted to share this. This was a really kind of a unique way of treating and having a largest check. Okay, so I'm going to get back into this $1 million minute. This is what kind of brings the practice to the $1 million mark and beyond. My MVP patient of the day. This was a 73-year-old female. She had really bad posterior tibial tendon dysfunction. And so I dispensed to her an AFO on the right, and she also got a custom pair of orthotics for her. So this is going to be the MVP. Why? Because, the brace, right? I use a medial blaze AFO, but she's not going to wear this brace all the time, and so that's why we got her an orthotic. So this is kind of a PTTD type of an orthotic while she's not wearing a brace. So the rest of the day, let's go into it. Starting in the morning, a 72-year-old female that got Swift number 3 out of 4. And this patient's doing a little bit better. We're going to do one more in a month. And the other thing, she was asking, hey, doc, how about these, they're hurting me in between. What can I do for these painful kind of warts because they have this callus that builds up on them? And I said, well, you can do Cara 42 and a pumice stone. So this is my go-to for painful calluses or painful warts. So they put the Cara 42 on there, and you can use any urea cream, right? So this is a 42% urea cream, and then they get the pumice stone. So this little kit is able to bring up your per visit value for that patient by about $50. Next patient was a 61-year-old man. He was right Achilles pain. He got Shockwave number 3 out of 4. Not sure why he's not getting 6. I think it's because I'm going on vacation and he might be going on vacation, but he's doing 4. So he's number 3 out of 4, already starting to feel better. Next patient was a right foot wound, kind of a distal tip wound. I debrided it. Patient had a kind of an ulcer, not tip, but like IPJ, hallux. It was due to the bunion, due to the shoes. So I put a felted kind of foam pad and a surgical shoe and things like that. I don't do a ton of wounds, as you can tell, but I was able to get a level 4 visit. I recommended a shower cover so they can keep this padding on there, on that area. She didn't get the shower cover, and so that's kind of my bad. I'm still struggling a little bit with communicating to the staff in the front about what people need to purchase. So instead of just, you can't expect people to buy it, you need to have a kind of a handoff process. I'm going to see them back in 1 week. Next was a 65-year-old, got an x-ray, number 4 out of 4 for EPAT to the second met head. So this is a gentleman that wanted to pay for speed. So a lot of our patients are willing to pay for speed. He did 4 shockwaves within about 2 weeks, every 3 days. Because he is an avid hiker, he's starting to feel better. Got an x-ray as a follow-up, and I'm going to see him back in 6 weeks. Next patient was a 56-year-old female, bilateral plantar fasciitis, and she had done Shockwave in the past, I think in February, and this has been about 4 or 5 months later, and she wasn't wanting to pay for Shockwave again, and so she did a cortisone, bilateral cortisone with ultrasound. So the self-pay for ultrasound, the office visit, and that. And then she said, hey, by the way, how about my nail fungus? And so when patients do this, I usually tell them about my fungal kit and things like that. She was just wanting to kind of get in and out. She's had previous LFTs, and so I prescribed her the terbinafine. So we're going to make a 2-month follow-up to see how she's doing with the cortisone, and then I'll look at her nails as well. Now, certain patients that are wanting to do the cortisone route, this is kind of how I do it. I just extend them out for longer periods of time because I don't think I can do much in shorter periods of time, and they're not wanting to do the regenerative treatment. So that's kind of how I do it versus seeing them sooner. Next patient was a 34-year-old female that came in. She had a recurrent ingrown toenail. We did a matrixectomy. Next was a 54-year-old female. We did a Cariflex on bilateral great toenails. Next was a 67-year-old male. We did an x-ray. He had bilateral, because of bilateral pain. He actually came for, he wanted nail care as well, so I evaluated the x-rays. There wasn't really much going on besides arthritis. And we did nail care for that patient, and they'll be back on my nail care day with my nail tech. Next was a 43-year-old female for left Achilles. I did an ultrasound today, and for the Achilles, I'm going to do a 3-week follow-up. She's going to do the night splint, foam rolling, morning stretch, everything like that. If it doesn't get better, then I'm going to see her back and do Shockwave at that time. So if it's not getting better with the traditional things, night splint, like all those other things, and PT. Actually, I think she wanted to go to PT. This is her second visit. And so I'm going to see her back in 2 months. So usually with patients, when they want to go to PT, I'll send them to PT. It might take a couple weeks to get in, so that's why I do an 8-week follow-up. And if it's not better at that time, I've prepped her for doing the Shockwave, which I think is what she really needs, but she just didn't want to. Next was a 59-year-old female, right hallux fracture, got an x-ray, cam boot, even up, and the fracture code. And so she had also on the other side left second med head pain. I'm not going to deal with that pain right now. I'll deal with that in the future. Hopefully with calming down the fracture, it'll feel better. So she's going to be back in 4 weeks. So usually for fractures, I'll just do one follow-up. I know you can get x-rays other times, but once again, when you're talking about like largest check patients or highest value patients, what are you going to get reimbursed for an x-ray versus like a new patient? So I know some people say, oh, you have to see everyone back at 2 weeks and 2 weeks and 2 weeks. Well, if you're trying to optimize to get to the $1 million mark, it's going to be hard unless you have someone else doing that, or you have these little 10-minute slots. I guess I could put them in the 10-minute slot for that, but I would prefer to see other patients in that slot. Next was a 64-year-old for a left status post 6 shockwaves. She's about 60% better to her plantar fasciitis. She wants to go to PT now, so I'm going to send her to PT. And then in 2 months, I'm going to possibly do an ultrasound and seeing how she's doing. And I talked to her, I might do a touch-up Shockwave at that time. So 60% isn't bad at 6 weeks because that's when the first session is starting to work, the first Shockwave session. So I think it should continue to improve for this patient. Next was an 83-year-old for left second toe. Came in, has a hammer toe. Had previously on the other side had a flexor tenotomy, wanted the same thing, so I did a flexor tenotomy. He's going to the Cape for the summer, and so I am not going to do a follow-up. I gave him my contact if he needs to contact me, so this is good because it's a little procedure. It should heal up fine, and they always get a 1-inch Coban, so they purchased that on the way out, and I'll see him back as needed. Next was a 69-year-old. This was in a 10-minute slot, so I'm starting to do my fractures in 10-minute slots now. Fracture follow-ups. She had a right fibula fracture, and she had 4 shockwaves, and she's an avid horse enthusiast, so she wanted to get back to her activity. And so after those 4 shockwaves, she was feeling much better. And so she was able to recover from this in 4 weeks versus like the 6 to 8 weeks, so her return to activity was a lot quicker. Next, 18-year-old male with an IND. And then for him, he had a really bad recurrent ingrown toenail. I couldn't do the matrix because it was just so bad, like this granuloma and all this other stuff. So I did the IND and I staged it. So in 6 months, he's going to be coming back for a matrixectomy. And then the final patient of the day, this was a nail care patient. And whenever I have like a 70-year-old male, whenever I have nail care patients, I always try to think of, okay, what else can I help them with? And this is something I try to look at with patients. And I even heard about, there are some other doctors that they used to keep like a list. Okay, I'm treating this problem currently. What are the other problems I can treat? So I tend to look at that with patients. I'm like, okay, how else can I help them? And one thing that really helps me is having my scribe. I think if I didn't have my scribe, I would just be so like stressed about like having to document something else that I wouldn't do it. So that's one of the benefits I think of having a scribe, is that you can think outside the box, and whatever you say and whatever you treat, they just document. Whereas in the past, like, okay, I'm seeing this patient, they want nail care, I'll do nail care, that's fine. Then they're going to come back on my nail care. But then I said, well, you have this nail fungus, are you interested in treating it? And they're like, yeah, okay. So then I explained the nail treatment. So they got the LFTs, they got the Lamisil, and they got my fungal kit, which is the UV light, the shoe spray, and then the biotin. So that changed something from like a really low value patient to a higher level patient. So I think those are the keys. As I mentioned this before, you want to reduce the low level visits, like just the plain like fracture follow-ups with just x-rays, ingrown toenail follow-ups, matrix follow-ups, reduce those, and then increase like taking everyone and bump them up with like a callus cream and a pumice like you've seen today, or bump them up with like another diagnosis that you're going to treat, or things like that. And then those that don't want the treatment, then you just extend their visits out longer periods of time, so that when they come back, they're more motivated to do the things that you're kind of recommending. So those are some thoughts. A doctor was asking me the other day, hey, do you do any coaching? I do a little bit of coaching for people, but I always ask that you fill out. I have a quiz, like an online on podiatrypracticemastery.com. There's a practice audit, and I put a long time putting this audit together. So basically, it's something you fill out. Just filling out this audit, I think, will bring up a lot of stuff, a lot of issues that you'll recognize. Hey, there's some gaps here that can help my practice. So if you haven't done the audit, I would recommend you doing it. Go to podiatrypracticemastery.com. Down on the bottom, it says an audit, practice audit. Fill it out, and then I will do a little recording of, say, hey, these are some ways that you can optimize things. Or if you want to meet, we can meet and chat sometime, and I can give you some thoughts. Okay. Hope that's beneficial. I'll talk to you tomorrow.